And we are live.
Okay, thank you. Good morning, everyone, and welcome to the Insurance and Pharmaceuticals Subcommittee of the House Health and Government Operations Committee. This is the committee where we take the bills after their hearing and work on them to see if we can get a pathway forward for the bills. We have 3 bills for us today. I expect that we will only be voting on one of these bills, but because on 2 of the bills, we need to have further discussion to get them prepared for a discussion next week. So our first bill is House Bill 247, Insurance, Medicaid Supplemental Policy Plans, Open Enrollment Period Following Birthday. And this is a bill from Delegate Resnick. Is Delegate Resnick here? He wasn't sure if he was going to be here or not. See no one.
Do not see him now.
Okay. Lisa, you want to tell us what the bill does and what the amendments do?
Sure. This bill requires a carrier that sells Medicare supplement policies to provide an enrolled individual the opportunity to switch to a different Medicare supplement policy with equal or lesser benefits within 30 days following the individual's birthday. A carrier is prohibited from denying or conditioning a new policy, discriminating in the pricing of the policy, or denying, reducing, or conditioning coverage because of the health status, claims experience, receipt of healthcare, or medical condition of the individual. A carrier is required to notify an insured of their right to switch plans at least 30 days, but no more than 60 days before the birthday. The amendments remove the word plan when referring to a Medicare supplement policy. They make provisions regarding pre-existing conditions the same for the initial enrollment in a Medicare supplement policy and during the special enrollment period for birthdays. They provide that the special enrollment period for birthdays apply to individuals enrolled in a Medicare supplement policy who have birthdays on or after July 1st, 2023. They authorize the insurance commissioner, and this is where there's a little bit of a change. If you look at, let's see, it's on page 3 of your packets, line 11. So rather than just having the insurance commissioner adopt regulations that define equal or lesser, there is it's not exactly a definition, but I guess it's a clarification of, so for purposes of this section, a Medicare supplement plan has equal or lesser benefits unless it contains one or more significant benefits not included in the Medicare supplement plan being replaced. And then the number 2 there requires the commissioner to adopt regulations that establish, instead of the definition, it actually gives the comparable Medicare supplement plans.
Go ahead.
And lastly, it changes the effective date of the bill to January 1st, 2023.
Okay, thank you, Lisa. When we left off last week, I had asked the representatives of the carriers to respond to the amendments. So, Kim, do you want to start with this?
Sure. Good morning, Delegate Cullison and members of the subcommittee. Kimberly Robinson here on behalf of Cigna. We did look at the amendments that were proposed last week by the Maryland, I know they weren't proposed by the Maryland Insurance Administration, but were in response to some issues flagged by the Maryland Insurance Administration. And I did meet with Mr. Cooney and Mr. Boone from the MIA on Friday. I think we had a very productive conversation. And the tweaks to the amendments that you have in front of you were provided by me in response to our conversation. The not quite definition, as Lisa described it, that kind of sets the parameters for what equal or lesser means in this context is derived from model regulation language in the Medicare supplement space, where that term is also being used. So it seemed to be a more widely understood way to express what we mean when we say equal or lesser in this space. And based on the conversation with the staff from the department, instead of having them have to create a definition in regulation, we would rely on the existing definition or the existing explanation of what lesser or equal means. And then what they would do is what some other states have done, not all, in the small number who've done this, but a few of them have actually just sort of published the crosswalk or the matrix of the order of precedence for what policy replaces which. Medicare generally has its own schedule of what the benefits are based on the letter of each policy. So there's a plan A, a plan B, a plan C, et cetera, et cetera. And generally speaking, the higher in the alphabet, the letter, the richer the plan. In the introduction of some different cost sharing, there may be one or two anomaly plans that there might be some conversation about whether they work exactly in their order, or maybe one or two plans is a little out of place when you take in the cost sharing into consideration. And so for that reason, the MIA wanted the ability to still evaluate rather than just simply adopt the Medicare crosswalk, which seemed reasonable. So instead of them creating the definition, they would be creating the crosswalk based on this statement of how we evaluate lesser and equal, which I think is generally consistent with how other states have handled it. So I haven't heard any pushback from the department on the language that Lisa's had, so I'm hoping that they're comfortable with it. While we still don't love the bill, and we do have a concern for what will happen for some consumers who may find themselves in higher prices, if you're going to pass it, we think this at least makes the bill operational for carriers, and we appreciate the effort to make those changes.
Oh, thank you, Kim. But so I wasn't clear. I think I heard that this language that we have before us includes those tweaks.
Yes.
Okay.
Yes. What Lisa sent you this morning reflects those updates. Absolutely.
Okay. All right. All right. Good. Matt, did
Much
you
better
want to say?
than I wrote them. She did an excellent job of making mine better, as she always does.
Yes. Matt, anything?
No, thank you, Madam Chair.
Okay. Is there anyone who wants to speak to the amendments on the bill? Is there anyone willing to move the amendments?
Move the amendments.
Oh,
Second.
do I have a
I would like
second?
to say-
Okay.
Okay.
All right. Jim Gutman?
Yes, thanks, Jim Gutman of AARP. Good morning, everybody. I was not able to be at last week's session, so I apologize if this was covered, but the amendment that excludes or limits benefits for losses incurred in the first 6 months is a big potential problem that defeats part of the purpose of this, because the people who are going to want to switch are the people who do have pre-existing conditions, and that's a large number of Medicare people. So I understand we have to try to find a way to make this workable, but I would hope that was covered last week, and that you're still thinking about perhaps an alternate way of doing this.
Mr. Gutman, the issue with that part of the bill is, and this was brought to our attention by the Maryland Insurance Administration, is that it aligns with what how the federal government governs Medicaid supplement or Medicare supplement programs. So it's simply aligning our laws with the current federal law. And while I appreciate and understand your concern, I think we want to be as much as we can in line with those regulations. Kim, did you want to add to that?
Yeah, I think the one thing I would add, as the commissioner's staff talked about it last week, I think it's also important to recognize that what that language says is that if you are coming from a policy and you're switching, which I think is sort of the vision for most of the people who would be doing this, right? You're in a policy with carrier A, the birthday comes, you want to switch to a policy with carrier B. Even though that pre-X language is there, you get credit, quote unquote, for the coverage you already had. So as long as you were in your previous policy for 6 months, you don't get a new 6 month pre-X. Essentially, you buy your way out of it by having had coverage already. So I think it reads a little more concerning than it actually is in practice. And I just want to make sure that that was understood.
Thank you for that clarification.
Thank you, Kim. That's really helpful. Any other questions or discussion on the amendments? Seeing none, we have a motion on the floor on the amendments. All those in favor of the amendments, please say aye.
Aye.
Is there anyone wanting to be noted in opposition? Seeing none, it passes unanimously. Can I get a motion on the bill as amended?
Bill is amended.
And a motion, and a second?
Second.
Any further discussion on the bill as amended? I see Delegate Krebs.
Thank you, Madam Chair. Thank you for the amendments. I think it makes it more clear. Is anybody here from Care First?
I don't think so.
And I'm assuming, and maybe,
Yeah, so
Oh,
I'm sorry.
there she is.
Kathy, Grayson and I are both here, but I see Kathy popped on first, so I'll let her talk.
well, the question I had, and I don't know if the amendments address this, but tell me if they do. You wrote about the churn, about people getting in and out based on what's happening in their health situation. Will these amendments correct that concern about people, sort of back and forth in and out of coverage?
I don't know that they will, delegate, but from conversations we've had, we understand that there's a will to move the bill anyway. There were conflicting witness statements about how much that churn would be realized. Our actuaries do think that it could inflate premiums, as we noted in our testimony. I think Ms. Robinson and Mr. Celentano's testimony reflects same. But understanding that there's a political will to move the bill, we do think the MIA amendments help. We'll certainly report back to you all once we have some data and experience on the effect of churn, which we do not have today because we only participate in the Maryland market, in DC and Virginia, not the birthday rule states.
No, but I think last week, Kim was going to find out how other states dealt with the consistent approach, which I understand that, but there's other states that have history behind this. And the last thing I want to do is see other people's rates go up because of this. I mean, I understand why people want to do it. I just don't want it to be abused with the churn. And that's what I want to make sure we have some guardrails around that possibility.
Kim, did you want to speak to this as well, or?
Yeah, I mean, Delegate Krebs, we are a company who does write Medicare stuff across the country. And so we through this year through AHIP, we did oppose the bill. We do have exactly that concern. I think to Ms. Grayson's point, we understand that there's a lot of strong feeling to move the bill in the General Assembly. That remains the reason why we don't care for the bill. We really, really appreciate Delegate Cullison and the opportunity to try to make what we feel is a bad bill better, so that at least it is something that we can operationalize the best way possible in the state. But what we know is that there are going to be individuals who, if people move out of their plan or people move into their plan and the guarantee issue with their more significant health costs, or they weren't in the plan when they were healthier, that's what happens when we cause that churn. That's what happens when we cause rates to rise. And so it's not a wholesale, the whole market has this experience, but there will certainly be certain plans and certain individuals who are going to get caught because of this shift in how Maryland is operating these medical centers.
And Madam Chair, thank you for that explanation. Madam Chair, I was on the call last week, but would it be something to consider putting a sunset on this, just so we have some information to look at a few years from now to say, did this cause rates to go up for other folks? Because that's my concern. I see the benefits for certain people, but there's always a backside, just so we would make sure we're not negatively impacting some other folks and their rates are going up because of this. Is there any indication of doing that, like 3 years, 5 years out?
Well, we hadn't discussed that, Delegate, so it's not something that we've considered. We do keep track of rates pretty closely. Our MIA monitors rates every year. The carriers have to propose their rates in, I think it's May, right? Maybe even sooner, and for the following year. And so there's a lot of analysis that goes into that. So, I mean, I think we will be looking at that.
Is that something that the MIA would look at specifically, how the birthday rule impacted X rates, and then we would know, yes, this is what it did.
Okay, so I've got two people from MIA who have more information than I do. So let's go with Brad first. Brad Robin.
Yeah, I mean, on this rates issue, I mean, isolating how the rates have changed due to this bill versus how the rates have changed due to other factors, claims trend, change in admin costs, et cetera, is going to be difficult, if not difficult to do. I think conceptually we know that this is going to cause some rates to increase and other rates to decrease. And for the market in a whole, we don't expect much of an impact, but it's going to take a significant amount of effort to isolate this variable from the other variables. And it's probably something that we would need to wait a couple of years to do to have enough credible data to try to disentangle those two pieces. It's not going to be something that's self-evident the next time that these carriers file their rates.
Thank
I had wanted to bring up an issue on the language around Amendment 4 that I am seeing. As far as the language that says a Medicare supplement plan has equal or lesser benefits unless it contains one or more significant benefits not included in the Medicare supplement plans being replaced. I'm concerned that language is going to restrict the type of matrix that we can make and make it so that the matrix does not make sense. And specifically, I'm thinking about plans F and plans G, where there are two versions of both of these plans. One is a high deductible version with a $2,490 deductible, and the other is the normal version and has a $0 deductible. And when you compare those two plans, Plan F and high deductible Plan F cover the exact same sets of services. So under this definition would be considered equal or lesser, but removing a deductible is not a change that would generally be, you would, going from 2490 to 0 is increasing your benefit. It's something that somebody would only do if they, thought they were going to have claims and would generally be considered buying a richer benefit. And so on the matrices that I've seen from other states that have the matrix approach, you generally are not allowed to switch from high deductible Plan F to normal Plan F. And I think that we would want to emulate that, but I'm concerned that language in that first paragraph, the way it is written right now, doesn't take into account the high versus low deductible issue. And that's for both Plans F and Plan G, have those two versions.
Okay. David, do you have anything to add to what Brad said? David Cooney.
Thank you, Delegate. No, I just wanted to make sure that we got your attention. Just apologize that we overlooked this when we looked at the amendment last night, and just Brad just realized this in the last second. So just our apologies to the subcommittee. Do you think it's a valid point?
Is there a way to tweak this language that will address that high deductible? Now, you said, Brad, in other states, you observed that you weren't allowed to move from the high deductible plan into the plan without the high deductible. Is that right?
Correct. In states that have published a matrix, there is consistency in all those states that you cannot move from a high deductible plan to the no deductible plan. And so, I think if we need to get language about that, we need to add a section that it's not just benefits. I would say we need to add a clause that says, or unless it removes a cost share, because that's what's going on. I mean, you're removing the $2,490 deductible to go from high Plan F to normal Plan F, or high Plan G to normal Plan G. So I think that would be sufficient. This language, or if a deductible is being removed. I mean, those are the only instances where two plans cover all the exact same things. I think that's the only issue there is. I mean, I think
if there were a one Roman numerals 1 underneath that said, that addressed the issue that a person may not switch from a plan with a cost share to one that does not have a cost share. So, I don't know that that's the right word, but is that
What about
what you looked at, Lisa?
Well, what I was thinking is based on what Brad just said. I don't know, but I mean, if we split it up after the word unless, so unless, and keep that language there, or if a deductible is removed, is that what you said, Brad, or something about cost sharing? I'm not sure which one, but I mean, I think.
Yeah.
Madam Chair, I actually agree with Mr. Bobin, and that's a I think that's a reasonable, and I think that's a change that we would support. And I'm happy to offer suggestions on the language, but Lisa just started going down the path that I would have suggested, which is just to acknowledge that the cost sharing gets taken into consideration. So I don't think that's hard to solve, and I think it accomplishes what everybody's looking to do. And we agree with that being important, that's one of those places.
Okay, thanks, Kim. Delegate Kelly.
Yeah, I don't want to add to the chorus. I think I was going to suggest what Lisa was suggesting, that Kim also seconded or thirded. So I think we're all on the same page, that there's a way to clearly do this in the language to get it at the high deductible plans.
So we actually have a motion on the floor on this bill, and we were in the middle of a vote. So I'm going to take us back to the discussion on the bill before we took the vote. And I am, Lisa, so what I'm going to ask the committee now is if we could agree to conceptually making the change, including language that addresses the issue of the high deductibles under, in the interlineated copy, it's under line 11. That's page 3 of the packet, so that we would split Roman numeral 3, number 1 into 2 pieces. If folks could agree with that conceptually, could we move the bill today? Is there anybody who disagrees with that? Any member of the committee who disagrees with us going forward with this conceptually to the whole committee? I see no hands. So Lisa, can I leave you in charge of with Kim and Brad to do that language? And
Yep.
Can I ask for a motion that will accept this amended bill, further amended bill, conceptual amendment to move for recommendation to the whole committee? Can I get that motion?
Move
So
the
we'll accept the bill with the
Okay.
conceptual amendment that we consider the impact of the cost share or deductible. Just consider the
Okay,
cost.
thank you, Delegate Krebs. That's a great way to say that. Is there a second?
Second.
Okay, those in favor say aye. Anyone opposed, please raise your hand, the virtual hand. Okay, and then it is unanimous. Thank you very much, all of you, for working this through with us. I really appreciate it. Now folks really understand what the subcommittee does in terms of how we work with the bills. We're going to move to House Bill 536, Maryland Insurance Commissioner Authority, Federal Health Emergency. Delegate Pendergrass. Lisa, what does the bill do?
This is an emergency bill that requires the insurance commissioner to adopt regulations that may be applied when a national or public health emergency that within the commissioner's discretion affects the state is issued by the President of the United States under the Federal National Emergencies Act or the U.S. Secretary of Health and Human Services under the Federal Public Health Services Act. A regulation activated in response to a national emergency or public health emergency may not apply beyond the duration of the president's or secretary's declaration. And then there is also uncodified language in the bill that requires a carrier that issues Medicare supplement policies to offer a special enrollment period for certain individuals enrolled in Medicare Part B and Medicaid. There is an amendment in your packet and on the last page of the packet, page 7. And it's just a technical amendment to the termination provisions. It's my understanding, though, that there might be some other amendments that need to be adopted as well that we don't have the language for yet.
All right. Thank you, Lisa. I'm going to go to Commissioner Bahrain first to give us some thoughts on this. Thank you, Commissioner.
I had the opportunity to speak to Mr. Celentano this morning. I think that if my understanding is correct, and Matt, don't want to speak for you, so please correct me if I got anything wrong, but I think that the league is going to make a suggestion that they believe will right-size the kind of federal emergency that's intended here. This language sweeps in perhaps a number of circumstances that no one intended to sweep in, sort of more standing federal emergencies, like, for example, the opioid crisis. That is no one's intent that would trigger our ability to use our emergency powers. So Matt has kindly offered to provide some more appropriate language together to right-size it, which we're happy to work with him on.
Oh, thank you, Commissioner. Matt Celentano, you want to?
Yes, thank you, Madam Chair. And first to the MIA, we are so sorry we're coming in this late. As somebody caught it last night, we did not chime in on the bill and we feel terrible, but on a second look, I'm glad we caught it. The bill includes a national emergency at the declaration of the president. Some of these include that are current national emergencies, blocking property of persons who threaten international stabilizations in the Western Balkans. There are about 70 more like this that would get wrapped into this bill. There are two concurrent public health emergencies, obviously COVID-19, but the opioid crisis has been a national or a public health emergency for over 5 years now. And unfortunately, I don't see that ending anytime soon. I mean, there's some incredibly interesting stuff on here, though. Blocking Sudanese government property and prohibiting transactions with Sudan. I think we want to get to the intent of the legislation, which we are all in agreement with, but the language just needs to be tweaked a little bit. So if you would let our appease my indulgence, we will get you some language. Thank you. And once again, I'm so sorry for coming at the last minute. So sorry.
I'm glad you caught it before the subcommittee, so thank you. Is there anyone, so I'm inclined to hold this bill to give them time to work out this this language. Anyone opposed to holding the bill? Anyone who would like to discuss the bill further at this point? Okay, seeing no hands, then know that this one's coming back next week, so we'll have the language then, right? And we will go to the last bill of the day, which is House Bill 421, out-of-state healthcare practitioners, provision of behavioral health services via telehealth authorization. Lisa, what does it do?
So this is an administration bill. It authorizes a healthcare practitioner who is not licensed in the state to provide behavioral health services via telehealth to a patient located in the state, subject to specified requirements. To provide behavioral health services via telehealth to a patient located in the state, a healthcare practitioner who is not licensed in the state must hold a current, valid, and unrestricted license issued by an applicable healthcare licensing authority in a U.S. state, district, or territory. They must not be subject of any past disciplinary action taken by or pending disciplinary proceedings of another applicable healthcare licensing authority. They have to act in full compliance with all applicable laws, rules, and regulations in the state, act in compliance with any state requirements regarding the maintenance of liability insurance for the practice of the healthcare occupation of the healthcare practitioner, consent to the jurisdiction of the relevant health occupations boards and courts in the state, and if applicable, hold a controlled substance license or permit.
Thank you. And there are no amendments, correct, Lisa, on this one?
There were some amendments that were requested, at least there was one amendment requested in written testimony, but nobody's asked for it to formally be drafted.
Okay. So Jake Whitaker, I'm going to ask you first to talk a little bit about the bill. You're the representative on this bill, correct?
That's correct. Thank you, Madam Chair. What I will say is I've reached out to one of the boards for technical assistance to make sure that there's stronger language on a verification process to make sure that the out-of-state licensee is in good standing with the state that they're licensed in, as well as don't have any disciplinary action. So I'd ask the subcommittee if we could table this so that we could consider some amendments that'll strengthen those verification processes to address some of the concerns of the stakeholders.
Okay. I'm perfectly willing to hold the bill, but I would like to take a few moments to make sure that we know what the issues are so we can address them as you work through it. So I see Kathy Grayson first.
Thank you, Madam Chair. Kathy Greason on behalf of Care First, and thanks to Mr. Whitaker. You know, we had talked about some of the concerns we had with the bill. One of which being that the way it's drafted, we don't feel that the Maryland board has enforcement authority and adequate oversight, even though there's provisions that would aspire to having people consent to oversight. We're not sure if it gets there legally. The concern with that is that the Maryland licensing standards are very carefully deliberated. I'm looking at Delegate Kelly, who, you know, your committee works on this all the time. Just let anyone in. There's a chance that another state standards that aren't as stringent would be the enforcement forum. And we just want to make sure that patient safety is adequately protected. So we would love the opportunity to review Mr. Whitaker's conceptual amendments there. And then the second issue we wanted to flag concerns networks. So Care First is a regional payer. We operate in Maryland, DC, and Northern Virginia. We absolutely appreciate and support the goal of better access to behavioral health. It's something we're all working on. However, by opening up telehealth to expand the pool, there's sort of this implication that the policy goal will achieve better access for patients, and we're not sure that that's the case for at least our members because of the network structure. So our concern would be if a member, leverages out-of-state telehealth services from a provider that's not in network, that patient would end up with an unforeseen balance bill, not understanding the nuances of sort of that national network scheme. It's something that we're looking at internally. And absolutely willing to talk through. We just want to make sure that from a consumer perspective, folks, if this bill were to pass, don't view this expanded national network as implying that their insurance will necessarily cover those individuals that may not be credentialed, that may not be in our network. So just wanted to flag those two issues, Madam Chair, and appreciate the opportunity.
Yeah, thank you, Kathy. That's really helpful. Robin Elliott.
Good morning. I am here representing Maryland Nurses Association and the Maryland Community Health System. We have some similar concerns. Just want to highlight, we agree with Ms. Grayson around concerns about patient safety and the ability of boards to really regulate these providers. We do want to raise an interesting question. This is telehealth only, which is not necessarily a bad thing, but just want to raise that we're really trying to, the extent we can, create permanent patient homes for patients. And sometimes that may involve both in-person and telehealth. In some cases it might. And then the last thing is, and I think Ms. Grayson touched upon this, the way this is structured, we think it will primarily increase access to services for people who are self-pay, because the likelihood that somebody coming from out of state who may have several patients in the state of Maryland is not going to enroll in an insurance plan or in Medicaid. So we see somewhat of a limited benefit for most of the Maryland population that needs services.
Okay, thank you. Scott Tiffin.
Thanks, Madam Chair. I think kind of most of the points have been addressed, but I'm here on behalf of the Social Worker Association as well as the OT Association, and just wanted to flag maybe one other possible concern, which is that the bill isn't super clear how it interacts with the obligations on the state under the compacts that we're already in, and future compacts that we might join. And at least we see the compacts as the ideal way to provide for interstate practice. They address a lot of disciplinary concerns and data sharing concerns, and it's just not super clear how this bill interacts with the compacts that already exist.
Thank you. Delegate Kelly.
Thank you, Madam Chairman. So something that Ms. Elliott said, and actually following on what Kathy Grayson said, sort of raised a red flag for me. So I guess this question is to Robin, although, feel free to direct it, whoever. But is it possible that by going down this path, we might be inadvertently undermining the larger goals that this committee has had in terms of network adequacy, particularly with regards to behavioral health and making sure that we're sort of moving forward with strengthening that, which is a problem we've identified for a long time, that it might actually inadvertently sort of create a solution for those folks who are private pay, or a potential partial solution for folks who are private pay, and sort of distract us from our larger goal, which is improving network adequacy across the board, particularly in behavioral health, and making sure that everybody can access those services?
I think it does create some very interesting dynamics in the marketplace in terms of providers in Maryland being able to attract practitioners and retain practitioners, retain patients. And so we really don't know. Florida did something similar about 2 years ago. I think a couple of other states have started to look at these models, but it is in large part untested. So I think you're raising a good question. It's certainly a possibility, and something to be concerned about and dig into deeper.
Thank you. Jake Whitaker?
So I would just add that the Medicaid program already serves out-of-state licensees. So if an out-of-state licensee wants to register in Maryland to serve Medicaid patients, that out-of-state licensee can do that. So I just want to emphasize that there are about 1.5 million Medicaid recipients that could be served by this bill.
Okay. Are you speaking specifically?
Sorry.
I'll take you next, Delegate Kelly. So that 1.5 million, is that relative to behavioral health specifically, or is that in general?
So that would be the total Medicaid population. That's an estimate of the total population.
Right.
But this bill would be specific to behavioral health services.
Okay. And you said, how is that happening now? Do those individuals have agreements with Maryland Medicaid, or?
So my understanding, for example, if an out-of-state licensee, for example, in Virginia, wants to serve Medicaid patients here in Maryland, that out-of-state licensee can register with the Maryland Medicaid program and serve patients here in Maryland.
Okay. Delegate Kelly, did you want to follow up?
Yeah, thank you. Sorry, Delegate Cullison. I think my question was more related not to the Medicaid population, but those folks who depend on insurance coverage to cover their healthcare needs. One of the challenges we've discussed for years in behavioral health is that insurance coverage is not necessarily comprehensive enough in terms of the networks and the providers that they have. And so many people who can afford to pay out of pocket for that care are doing so. And I wouldn't want to go down that road. So while I appreciate the answer about the Medicaid population, my concern is specifically for the folks who are in the private insurance market.
Great. Thank you, Delegate Kelly. Delegate Bandari.
Yeah, thank you, Madam Chair. This question is for Jack from administration. I do understand that when we practice this law, the distant state licensure requirement might be different. That might be stringent and might be protective or less protective than our laws. Like one of the examples is a licensed psychologist in Maryland must possess a doctorate degree. Other state, however, allow psychologists to practice independently with a master's degree or far less experience and training. How is that compatible? What do we do under this law?
So there's language in the bill that requires that the out-of-state licensee adhere to the requirements of the health occupation boards here in Maryland. To your point, though, I think that is an important point that you raised, and I think we'd be happy to work with stakeholders. And I reached out to one of the boards this morning to kind of strengthen that language to make sure that we have kind of a stronger verification system in place.
Okay.
Thank you.
Thank you. Anyone else who'd like to raise a concern, an issue, a question that can be worked on in the week between today and next Tuesday? Okay, seeing none, then we know that this bill will be coming back to us. If we're not ready next Tuesday, we'll come back when we're ready. Jake, I invite you to work with the folks and see if we can't get language that meets a lot of the concerns that have been raised today. Are there any questions from members of the committee on any of the actions of the subcommittee today? Seeing none, then this concludes the meeting today, and the Health and Government Operations Committee will be meeting at 1:30 for bill hearings. Thank you all and have a great day.